Friends of Public Health from our campus who join us for this series. Professor in statistics has been here at UCI, essentially started statistics program here, and a very good friend to public health and many initiatives on campus. Dr. Butler, so he's always welcome with us. Anybody else wants to ask Dr. Iyer anything about his life before we start? And he likes to tell the story of how it's not about what he's supposed to talk about, is how long do you want him to speak? That's right. So don't ask questions that could provoke him into Hello, how are you? Eric is a PhD. Okay, well, are you able to stay for lunch?
Sure.
Okay, so you'll get a chance to meet other students at the time. It is my distinct pleasure to introduce Dr. Kris Iyer, who is the medical director for the Mary and Dick Allen Diabetes Center at Hoag Hospital in Newport Beach. He's a great friend of public health, revealed in part by his commitment to a population-based management of diabetes, one of the biggest disease burdens that the country and the entire world actually faces, and it's growing. He's practiced medicine internationally. He's served on many boards to guide how we do medical practice and public health effectively. He's won many awards, and he's also one of the beneficiaries of student education for the public health program here. We've placed some of our students in the diabetes clinic, and so he's a teacher, he's a medical practitioner, and just a wonderful human being, and I'm looking forward to this presentation. Thank you.
Thank you, Dilip. My voice does carry. The only problem I have is I tend to speak a little too fast, and if you feel that way, raise your hand and I'll slow down. Thanks, Dilip. Dilip and I have come to work together the last few years, and the best is yet to come as far as Dilip is concerned and our center is concerned. What I thought I'll do is give you a brief background about Mary and Dick Allen Diabetes Center, about Hoag Hospital, and then I'll expand it into diabetes as a public health problem. Then I will challenge you to take up the offers at the center that you have. So let me start by saying the history of Mary and Dick Allen Diabetes Center. I was chief of staff in 2001. Those of you who do not know medical politics, chief of staff is an elected position at Hoag Hospital. The term, we are the officers of the medical staff. The state of California expects the medical staff to be independent of the administration for the simple reason that the patient should be taken care of, not because of the cost it will be, but because the patients have to. And because doctors are trained to be uniquely qualified to run patient care affairs, all medical care affairs in the state of California must be driven by medical executive committee and medical staff. And the board of trustees are ultimately responsible for everything that happens, and they are forced by law, Title 22, to make sure that the medical staff is adequately funded, to be self-regulating, so that the advice and consent that they provide to the board regarding clinical matters is by the medical executive committee and medical staff. And there are various definitions and various commitments that medical staff has to make. It is not to protect their own self-interest, but to protect the interests of the patients, and the state of California insists on that. Hence, the medical staff elect their own officers and their own department chiefs, and at Hoag Hospital, the term for the officers is 6 years, 2 years as the chief of staff elect, 2 years as the chief of staff, and 2 years as the ex-chief of staff. The chief of staff at Hoag Hospital carries probably a very powerful position. It's third only after the chairman of the board, the CEO, and the chief of staff. I was very fortunate to be elected, and when I became the chief of staff, had already been involved in the development of various protocols for diabetes. I met the chairman of the then chairman of the board, Mr. Allen, whose granddaughter had become diabetic at the age of 2 just the previous year. So he was passionate, he was driven. So with his help and the then CEO help, we started a small diabetes education center at Costa Mesa. That education center then started becoming bigger. With a lot of help and support from various people, we went to the board, went to the community, and said we need to have a comprehensive diabetes center. Whether it is right or wrong, most of the policies that we have developed, some of us at least, always develop those policies by asking the people who deliver and asking the people whom we serve. We wanted them to be part of the program that we evolve around them. So Mr. Allen wanted a diabetes center. So he said, go ahead and prepare a business plan. I'm a doctor. I don't know business plan. I did something, and his office actually was across here in the tall building, UCI, where Chakra restaurant is and all those tall buildings. So his office was here. I gave him the plan. He's such a nice man. He doesn't comment on your bad qualities. He approaches life with, if you are good, let me work with you. So he put it aside. Then a couple of years later, he said, Kris, dream. Dream as far as you can. These are his words. We were sitting in that office. And if you were given everything that you want, and if you want to provide care for the diabetics, come up with a plan. I had an administrator at that time who was a close friend of mine. He's now the chief administrator at Hoag, Mr. Braithwaite. He and I sat down and started working. My mentor was Dr. Joe Shipp, who has set up diabetes clinics all over the world, and he goes to India even now without taking malaria tablets, and he has set up clinics everywhere. So he's my mentor, and I asked him how to do it. So we came up with key elements, which are that it will be comprehensive, which will serve everybody, and especially the underserved, and without consideration for ability to pay, and it shall never close. Because, ladies and gentlemen, economy is bad. Hospitals, most of them, depend on the profits they make. The margin in a hospital is about 3 to 5%. Margin in my office is 55%. So the hospitals have to be very, very careful how they spend the money. Diabetes program does not produce money. The first program they will stop in any hospital is diabetes program. It is true everywhere. So we had to have all this in place, and we presented a business plan, and Robert negotiated the chart, because if there were no children, it is not comprehensive. We underserve children. Folks does not know how to take care of children. So we need to have them. We need to have all the doctors. We need to have psychologists, social workers. We need to have educators, all in one building. So we prepared a plan and submitted to the then board of directors and the chairman. By then we had a new CEO, a new chairman, and Dick approved the plan, and the board said, go ahead. It was going to cost us $9.5 million. And we went to the foundation, which raises money for us. So I remember presenting it. And they said, why 9.5? Why not 18? We said, fine. Then the business office came and said, Dr. you cannot run this at 18, so we need to have $24 million. So we had to raise $24 million in order to do all of that. We've raised 11. And we'll raise the 24 within the next 2 years. That's because people in our service area are very generous. But the program cannot be because what I want or what the nurses want. So we contacted all the people who deliver care in the community. Children's Hospital of Orange County, JDRF. You can see JDRF walk next week or this weekend. EDA, Latino Health Access. All the people, we put them in one room. We said, we're going to develop a center. By the way, the board name of the center is Mary and DeKalb Diabetes Center. So these people, and our own community medicine department, we make a lot of profit, but most of the profit is either put back into the community or to the building, or we have a community medicine department. Sole function of the community medicine department is to disperse funds from our profits, from our operating profit. And we have to call them in too. Some of you may already know about the Department of Community Medicine. So we developed that center, we developed a program. The program will be that we'll take care of children. CHART was given the sole responsibility. We take care of young adults, we develop a program. Then we will take care of the elderly, we'll take care of pregnant women. So those were all in it. When we talk about underserved, we talk about children, Hispanic population, other populations. So that's how the center was formed. Whole diabetes care has always been in the forefront. My wife always tells me when you talk like this, it looks as though you're gloating. I gloat with great humility because Hoag has given us a lot of resources. The resources are almost unbelievable. I mean, I'm really very happy at this moment because whatever we ask for, they give it to us in order that that's the right thing to do, the patient will benefit. So we started improving diabetes care many years ago when we improved error reduction. When the doctor called, like 2 o'clock this morning, I got called for a patient's blood glucose and I had to give insulin. And there were many errors that were taking place. So we formed the first super team, which was medical error reduction team. So we organized a way of ordering the medications in a standardized form, except that I will convey my sincere apologies for doing that. I created a monster which was bad. We created an order set to deliver orders for insulin, which is not the right thing to do. But I soon made up by changing those order sets. So that was the first experience. Then we, in the early 2000, 2003, reports came about saying that if you manage diabetic patients or patients with high blood sugar very tightly in critical care, you can reduce death, reduce length of stay, reduce complications. So went to the hospital administration and quality improvement committee, and we said we want to reduce that. So we developed a algorithm-based insulin treatment which was standardized with less variation. And that's what we are supposed to do. So that became very successful. Then the quality department said, would you like to do that in the entire hospital? So I'm a glutton for doing all these things. You see, moving the dot has always been very passionate. So we developed hospital-wide program. We are one of the 300 hospitals in the country which uses only 3 insulins in the hospital. We do not have any other medications. The doctors are like Captain Scully. You know, Captain Scully has control tower directing his traffic. You remember Captain Scully who landed the plane in Hudson River? What did he do? Every pilot has the same way of contacting the control tower. So the control tower contacts the pilot the same way. There can be no changes. It's flight 230, turn left. Pilot will say, control tower, flight 230 will turn left. And that is standard. They have to read through the log, they control. All flights are controlled. But algorithm-based treatment, when it is controlled, doctors resent it. You know why? Right from the day we go into medical school, we are pounded. You are responsible for your patient. You are responsible for your patient. You are responsible. Anything happens to your patient, you are responsible. So we develop this God complex because, and then, you know, all of you know that. I mean, we think we are superhuman beings because we are made to be responsible. We don't like people telling us how to take care of our patients because we're very jealous of our patient care. We take care of it very seriously. But when you give them predetermined order sets, they feel emasculated. They feel they cannot control it. But they are Captain Scullys. What did Captain Scully say when the control tower said, turn right, go to LaGuardia? He said negative, and he turned left and landed on Hudson, saved all of them. Now, so the order set that we created has resulted in cost savings for us because we do not have any other medications except the 3 insulin. The order set also has put us in the top quartile of the hospitals in the country. Decalin asked me why not the top decile, and we are this year. Only UCLA is better than us. So that was a major achievement, except that those orders which we created in the critical care are not found to be too dangerous. I'm sure some of you who are following medical politics and medications, if you manage critical care patients very tightly, 90 days post treatment, there was an international study done which showed that those people who were controlled tightly, they died more than those people who were not. So we had to wake up. So we have changed the entire order sets. We also will be giving intravenously insulin in a standardized algorithm-based manner delivered by a computer-based software, which will be starting 1st of January. They're all being trained. That's the endo tool. Hospital-wide, we have relaxed the standards. One order cannot fit everybody. So that is also will be approved by the medical executive committee day after tomorrow. Then we'll start. That is in the hospital. Remember, 85%, 90% of diabetes care is in the outpatient community, not in the hospital. But we have done some of this. So as I said, the key elements of the center were comprehensive, serve the underserved, and now without consideration for ability to pay, never shall it close. And we want it to be from cradle to grave. That's the basis of outpatient Mary and Nickel and Diabetes Center. This is the Mary and Nickel and Diabetes Center. Some of you have already come there and seen the place. Those of you who have not come and visit us, we'll show you around. It's a very fabulous center. We have children's wing, we have physicians' offices, we have conference rooms, small wing, family, and we're very happy. My office is directly behind that, directly behind. Keeping track of all the people who are working, making sure they're working. So, what are the projections for Orange County? I have those of you who are interested in more statistics. This is our business development office. They're a great resource for us. Whatever we want, they'll cull it out and give it to us. And I have the table at the end. I won't be talking about it, but if you're interested, we'll be happy to provide those details. These are projections. The population in Orange County in 2010 will be about 3 million plus. The utilization of population for diabetes in the hospital, male will be 71.2 per thousand, female 43. In the office, it will be 270 for males and 279 for females. And the expected visits in the hospital will be 75,846 and 250,000 in the office. I want you to remember this. There are slides coming down. Keep in mind this burden that is going to be. If there was ever a problem that public health, most of the details we have obtained actually are from public health publications. Nothing can be more important for this country, as I'm going to talk to you, than control of diabetes. I'll talk to you about some countries which have more diabetic population, how little they spend, how much we are spending, but we are not getting the bang for the buck. So what is the prevalence of diabetes? With that population, 5.5% of the people are diabetic, 1 the type 1 diabetics are slightly different. There may be some mistakes in the number. Type 1 diabetics are those people who do not have insulin. Majority of them are children, but they will grow up into adults because of the care that we provide. And type 2 diabetics are, majority of them are adults due to genetic, environmental factors and other issues. But we see 12 and 13-year-old young children weighing 200 pounds getting diabetes. So more type 1 patients are going to be older, more type 2 patients are going to be younger. Remember, the complications of diabetes are terrible. And what's the incidence of diabetes? This is what we expect, that 7.2 per thousand, 6.9 females will be diabetics, and new onset of type 1 diabetics will be about 2,835. There is a slight preponderance of females in type 1 diabetes. We do not know the reason for it. And the new onset type 2 diabetes, as it says, it's about 6 to 1, 7 to 1 more towards type 2. But we are seeing more of type 1s. So diabetes today, ladies and gentlemen, is the 6th leading cause of death. Heart disease is coming down. Lung cancer disease is coming down. People are not smoking. Heart disease, people are living healthy life, better medications. Automobile accidents, there were pulmonary diseases. As people stop smoking, as chronic lung diseases will get better. So diabetes is the next leading cause. Unfortunately, it's increasing, but it kills younger people because if you've had diabetes for a long time, and many of them type 1 start at 2 and 3, they have more complications. So diabetes is a burden not only for the cost of care, but from the mortality and loss of young and youth. And that's an important thing you must remember. What else happens if the cost of care is about $180 billion? We do not have the latest. This is 2007 and 2008, which should be published, I think, in about 6 months, the latest cost. That $180 billion is both direct and indirect cost. 22% of all hospital stays in this country is by diabetic. And in our hospital, 18 to 19% of our patients are diabetic. 23% of our patients who get cardiac surgery have diabetes. And leading cause of blindness in the ages of 18 to 42 is diabetes. Leading cause of non-traumatic amputation in the same age group is diabetes. Leading cause of renal failure is diabetes. One amputation costs $70,000. One patient on renal dialysis costs $150,000. It's not about amputation, it's not about dialysis, it's not about blindness. It's about loss of self-esteem and loss of productivity of those people. Imagine a 40-year-old, I have very few of them now, but I used to have a lot of them, sitting in the wheelchair, not being able to see, being hooked to a dialysis machine, cannot work. See you have many of them, and this is a sad story. Unfortunately or fortunately, all these can be prevented. That $180 billion, we are spending 51% of them in the 51, sorry.
No, given this amount of money and the patient load, I'm surprised that diabetes clinics are supposed to close in the economy. I mean, it seems to be lucrative in a bad sense, but where is the money going?
America has never helped itself. You see, we've been procedure-driven, we've been device-driven, we've never been community-driven. If there is one disease that begs for the community to be involved, it's diabetes. It's not a disease of the individual. I'm a type 1 diabetic. My wife is up most of the night with the pump going on. My daughter, my friends, everybody knows what my problem is. It is not a disease of the individual. It's not a disease I can take care of in my office. It's a disease that has to be taken care of by the community. But the way our health, I'm not being political here, the way our healthcare system is developed is for procedures and costly investments and devices. We have not taken into consideration the human suffering. We do not know how to pay for my services when I spend 30 minutes to a diabetic family. But I can pay $5,000 if I have to fix my hip. I can pay $10,000 if I have to have an MRI, because that's fancy device operation driven. Our healthcare developed from in the late 1800 and early 1900, trauma and infection. Those were the main reasons why American health industry is more towards devices and fancy. And we have the best equipment, we have the best talent to take care of it. But when it comes to cognitive, community-based treatment and measures, we are not doing that. When I was a GP in England, see, I got back to English accent for a second. I delivered babies at home. I took care of dying patients at home. I would give the Brompton cocktail. The cop would call me in the evening. Doctor, there was Brompton cocktail prescribed for the dying patient. They kept track of drug prescription. I would have health visitors every morning from 8 to 8:45, telling me which patients need home visits, which children needed to be seen, which mothers needed to be seen, which old ladies have to be seen. Before I started with general practice, I got a call one evening before I started. This is the vicar here. I said, Vicar, I'm not a Christian. Doesn't matter. You are the parish doctor. So St. Stephen's Parish meets every Wednesday in a church built in 900 AD. The pews were still made of stone. I had to be responsible for my brothers. And that is the way the society is. That's where most of my ideas about taking care of people came from. I didn't learn medicine. I learned how to take care of human beings. So that's a cultural shift. So how best we can do is what we have to approach this. So who else are responsible? If I am, as a Asian, I'm highly susceptible to diabetes, African Americans, Latino population, South Asians, which is me, East Asians, which is Chinese, Vietnamese, Arabs, Pacific Islanders, are all at risk for type 2 diabetes at 1.5 to 2 times more than a Caucasian. As you go on campus, the beginning of UCI, these are the junction of campus and Culver, and across is Uni High, University High School. I live in Irvine, by the way. I trained at UCI. How many languages are spoken in the homes of those children? Some of you who are from UCI cannot answer this question. From Uni High cannot answer this question. How many languages are spoken in the homes of children attending University High? Can anybody guess? Those of you who came from Uni High cannot answer this question. No, you cannot, because you know the answer. Try. How many languages are spoken in the homes of children attending Uni High? A mile from here.
24.
How many?
35.
35, 12, 50.
My daughter goes there, but I've never asked her. I've said
55 plus, right? Remember that big picture you had as you walked in? 55 plus. How can I develop a program for diabetes when I do not know how to explain to them in their languages? Majority of us are second or first generation immigrants. Even the children who are very Americanized, when they go home, they have to eat the same food that we eat. So we've got to remember that a public health problem of such enormous proportion, made worse by not being able to deliver care in the manner they understand and able to follow. So the United States is the capital of diabetes. You're not going to be there for a long time. Both India and China are chasing you very fast. So it's a competition with India and China. China has 1 in 10 of their population is diabetic. 10% of the population as being diabetic. India is the same, about 10%. Thank God for Americanization of the rest of the world. How come they became diabetic? It's because genetically they had the genes. But then when I go back home, not anymore, but when we used to go back home, in order to buy a bar of soap, I had to get out of the house and walk. In order to buy simple groceries, I can get into my car and go to the supermarket. We had to walk and bring back. So the society was made about lots of exercise, and we did eat a lot of carbohydrate, but it was burnt. The first generation of doctors who came to this country were from India. 27% of doctors in this country are from overseas. 87% of them are Indians. And the first set of doctors who came in the 60s with Medicare being passed, all of them are dead. They all died of heart disease. So they have a genetic makeup. They all became diabetic. Because our life became different. We started eating McDonald's hamburger. We drove in cars. We did not exercise. So we get into a car, come to 24-hour fitness a mile away when you could have walked there and come back. So the genetic predisposition, environmental changes, all make diabetes more obvious in this population. 8% of our population are diabetics. 1/4 of them do not know they have. We see patients for the first time with complications of diabetes. 50 million are risk for diabetes. And can you imagine the burden that the society is going to pay? While we are the capital, we'll soon be overtaken by China or India, depending on their increased exercise. So, according to some public health officials, it's a fabulous article. If you are interested, I'll be happy to provide this. This is the projection that we'll be spending $350 billion for the care of the diabetics. Now, so at Bailey and Decal and Diabetes Center, we cannot solve the world's problem, but if those elements were to be part of us, these are the programs we have created, and we'll be talking about that in a minute. It's our children's, it's their responsibility. We have a community support program. One of the interns from UCLA, she just finished her internship with us. She's a public health student from UCLA. She's coming back to work with us. She has developed a community-based program. Like we did, we do everything at the center. We asked all those people who needed support from us what they wanted, and we have developed a program in English, unfortunately, for the community. We also feel, those of you who are diabetics, who have friends who are diabetics at your age group, it's the most challenging time. When you finish pediatric care, which is done as a family, you come to adult care. In my office, it's 15 minutes, and majority of us doctors do not know much about diabetes. The patients know more, and it's a troubling time. Socially, emotionally, physically, these are challenging times. And there are a different group of people. They do not want parents, they do not want doctors, but they need help. So based on the experience of the family members, Herbert family, their family just opened their eye center, I think day before yesterday here. The family gave us a lot of money to develop a special program for young adults with type 1 diabetes between 18 and John is helping us with publishing that report. We have Sweet Success. Sweet Success is a program for women who get diabetes during pregnancy and who have diabetes, who become pregnant. We are the California affiliate. We have had some very good success. Our Spanish program recently got a state award. The Ubrath family, I'm sure most of you know who Ubrath is, Peter Ubrath for Olympics. They gave us quite a lot of money to develop a program dedicated to improving women's health with diabetes. We'll also be working on weight management, prevention of diabetes. Diabetes self-management education is the core of all diabetic care. Nutritional services, insulin management, physician consulting services, and translational research. I put this at the end because that, to us, is the most critical thing. Our work will not be recognized unless we partner with institutions like yours, unless we publish together, unless we work together to make sure that what we do makes sense and the other people can carry out. So if Miriam DeCallan Diabetes Center, let's go, they're a small department of our hospital. I mean, I talk big, but actually it's a very small department. And but it has big ideas, and we have already collaborated with UCI. We have UCI NA's project working on it at the center. We are going to work with Hispanic females. We're working with San Jose State University to develop a diabetes program for Asians because their food is quite different, and how am I supposed to take care of a person who, how many of you like Indian food? I cannot teach diabetes care for the Indian population because I haven't gotten any. So we have developed that. We're also working with John to make sure that our young adult program is successful. I think one of your interns, one of your students is going to start his practicum. Where's Lawrence?
Larry has a conflict this morning.
Okay. So I want, everything is over. He's starting soon. So we're going to even pay him actually to work there. And another young scientist of the year award is going to start working on pollution and the effect of pollution on diabetes. So that has also been approved by the way. So you're already working with us. UCI at the center, as I said earlier, Latino family program, we are going to develop instructional materials for taking care of diabetes. Diabetes is a major public health issue. Ladies and gentlemen, you've got to get involved in any of this. We are ready to work with you on any of this. We want to develop a culturally sensitive program. Once again, this is not politics, but we have failed to take care of our diabetic population by preventing them from coming into the hospital, by not recognizing what they want to learn, how they want to learn. I still remember Sherry, who is a passionate person with women and diabetes. She came one day and said, "This is all I have, this is all I have." 10% of our population, so women, pregnant women, are Indian women. See, diabetes care is affected by culture, economics, and ability to understand what we want to say. So the Indian women, they are highly educated, they have no financial problem because all of them are software engineers, but they go home and eat their own food. This is one page. That's all we had. So we have developed meal plans based on the food they eat, understood the calories that each Indian food will be able to provide for them. So we want to do that. You know what's the Hoag Hospital, Irvine, we opened 2 months ago. You know what's our population that we have to serve? 32% are Mandarin-speaking Chinese. 17% are Farsi-speaking Persians. So almost near majority are non-Caucasians. We cannot serve them unless we understand the way they like to think and behave. So all the programs that I'm talking about, whether it is self-management, whether it is community support, young adults, prevention, improved outcomes, reduced cost of care, we would like to work with you. And I'm sure all of you are passionate about this. And I was talking to you about the tables. These are the tables. So at the Marian Decal and Diabetes Center, what I'm offering to you today is for you to work with us in terms of the projects, short-term, long-term. We're not going anywhere. You're not going anywhere. So we are happy to collaborate. We already have some ideas about how to collaborate. And with Dili's support and your support, hope we'll be able to work something together. So with that, I'd like to leave some time for questioning, if you have any. And Dili, I promise you I'll answer very briefly. So. Any questions? Let me tell you what, I always do this. I give everybody a chance. So let's start with the last row. And if you don't ask questions, it doesn't matter. If you ask questions, that's fine. Anybody in the last row? Last row. You're not last row yet. Last row? Okay, go ahead.
I was just curious, can you develop diabetes from eating too many sweets?
Sorry?
From eating too many sweets, can you develop diabetes?
No. See, in order, if you were to think of diabetes as the body's inability to manage sugars, there needs to be more than what you put in. You must have the genetic basis, the environmental factors, obesity, lack of exercise, medications, infections. So eating sweets under those circumstances and not exercising with the racial and ethnic and genetic background, with other forces, you may start obesity and develop diabetes. To say that you will develop diabetes because you ate sugar is a fact. That's not true. Go ahead.
In previous slides, you mentioned about the 25% of the population doesn't know.
Yeah.
They know they have diabetes.
Right.
How do you assume that?
Right. Most of it is all, hey, public health people. You're the guys who are giving us all these facts. Let me tell you what it is. Diabetes is not diagnosed very early because there are no symptoms for diabetes. The excessive urination, excessive thirst, loss of weight, muscle weakness, all come much later. By the time you are diagnosed, 50% of your pancreas is lost. So we're already dealing with issues which are bad. So both by mathematical models and by scientific studies, we know that patients who have diabetes, because of lack of symptoms, that's the only reason. You know how I was diagnosed? So I was here in practice, started as an endocrinologist, and you know, device manufacturers come and show you their device, how it was good, and she tested my blood sugar, and I tell you what I ate that morning. I had eaten crow sandwich and with mashed potatoes and hash browns. So it was fairly 5,000 calories, I think. And the lady, after she tested me, she sort of went pale, blue, green, and red. She said, "Okay, doctor, I think my machine is not good." I said, "No, what's the problem?" I was perfectly healthy. I mean, I was happy. I was starting practicing. He said, "Well, no, my machine is wrong." No. What's the problem? My blood sugar was 270. I didn't even know. And here I'm an endocrinologist. So the reason for that is because many of them do not have any symptoms. That's why. You had a question.
Yeah. I was wondering if you could mention a couple specific projects or roles that we as students can come in.
Yes, actually I can. So you have diabetes self-management education program, that's the SME, which is the core of our function. That we need to develop for population who are non-English speaking population. We've got Vietnamese population, we don't know how to teach them. We have Spanish, we are developing that curriculum. We have Asian, we have Chinese, we have, so that's one. I mean, you can help us develop the program. We'll give you the core components and you can develop, tell us how to do it. Community support. How am I going to Chinese population and tell them these are the various services which have nutrition, education, exercise, cooking, but we need to do it in the manner that they feel comfortable with. Young adults. It is not only the Caucasians who get type 1 diabetes, even though it's predominant, but non-Hispanic, Spanish-speaking population are also getting this. There are very young people who child takes care of them and they speak a different language at home, different food at home. So, for prevention, this is the best thing. That 180 billion I talked about is 51% of it is complications. You know, if you are a person who is likely to be a diabetic, and we can identify those, by simple diet and exercise, that's what Lawrence is going to do. He's going to develop that weight management program for us. One of your students is going to start his practicum there. He's been given the task of developing weight management program. So diet, exercise alone, without medication, can retard the onset of diabetes. And maintenance of weight is though difficult, without medications can prevent complications. These are scientific facts, evidence-based care. So I think you can help us develop that. And you're all very good at assessing the needs, you're all very good at evaluating a program. You can help us do that. We have a new electronic medical record that we are going to be implemented, which is starting. We have 113 metrics. We've got about a few performance measures which we want to use. Dashboard, we want to publish it on our website, how well we are doing, how bad we are doing. You can help us develop that. We want to reduce costs. So we're going to various companies and insurance companies. If you came to our institution and if you followed our methodology of prevention, maintenance, or better control, we can reduce cost. Because cost of care, for me, pump, $10,000, $1,400 a year, supplies alone. That's a lot of money. That's a lot of money. Do you know? So you can help us demonstrate that, A, we are too expensive, reduce the cost, and we can translate it to other communities. None of them is proprietary. We're not going to own any of this. We'll happily share with others. And that's what we're doing. Do you know how much India is spending on diabetes care? Population of 1.4 billion, 8% of them diabetics. Anybody? Take a guess. Come on.
50 million.
50
Million.
1 billion.
They are going to spend, they just announced last week, $32 billion. And we are spending 180 plus. The method of evaluating a diabetic control is by a test called hemoglobin A1C, which is 3 months control. Do you know what's America's hemoglobin? 6.5 is the best. Anything above that is not that good. But 7 is okay. What is America's average hemoglobin A1C and what we get for $180 billion? Anybody? 7.9. Guess India with less than 30 billion. You know what their hemoglobin A1C is? 7.9. Go figure. We're not spending our money effectively. We could do better. Third, next row, question.
You can go first. Yeah, you let him first and I'll.
So can you go into a little bit more detail about the metrics that you have to evaluate the effectiveness of these programs?
Sure. Tell me, I'm wasting my time. I'll be happy to listen. Yes, we want, you see, what I learned by working with John and, John Billimek is from Healthcare Policy Research. He's been working with me for a long time. What you guys are very good at is understanding how the program is to be structured and how the effectiveness of the program. You can tell us, Kris, you're wasting your time. You will not succeed in this. Because we need to know that what we think is, though we have asked the people what they want, but we may have structured the program inefficiently. Most definitely, sure. That's what critical thinking is all about, and take instruction from anybody. If you do this, you'll get this. What you're doing, you will not achieve. See, at the end of the day, your program is successful or not is by the design, right? Design is it's all about design. And what do I know about design? I'm a doctor. I'm just, all I know is to take care of patients. So that's what we want. We want critical analysis of what we do, what will result. Question?
So maybe I can follow up. So, because it's not a curable disease,
Correct.
what is the single measure of success? I mean, how do you know that you're...
At this moment, isn't this sad? Such a vast disease. The hemoglobin A1C is the only marker. But those of you who are interested will be happy to share our metrics of success or metrics of better care. We have some very tough care metrics we have put for ourselves. We'll be happy to share that with you. Those are all processes. But at the end of the day, what's my role in life? Reduce suffering and reduce death. If I do not show that Mary and Dick Allen Diabetes Center reduce complications, sufferings, reduce mortality, death, I haven't done anything. So, but all those outcomes must have processes. Hopefully those processes will result in that route.
I hear a lot about the genetic predisposition of
Yeah.
diabetes, but is there a particular gene, or what does that exactly mean? Like, I just hear that a lot.
Excellent question. It's so easy to throw this out, genetic question. There was a study published. So the doctor was told, predict diabetes in a population. The lab, gene lab, says, we will predict population, which same group. So the doctor, by asking 20 questions at a cost of no more than $50, predicted how many of them will become diabetic. The genetic lab, at a cost of $10,000, predicted how many of them will become diabetic. The answers were the same. Therein lies that we are not yet very sophisticated in the diagnosis. There are many genetic predispositions, many genetics are being identified, but at this moment it is at the research lab, not at the bench, not at the clinical lab. So expensive, but not very satisfactory in terms of predicting. There are the one or two genetic studies which have demonstrated some patients with diabetes will develop cardiac complications. As you know, cardiac death is the single most common cause of death among diabetics. And many will not. That's about all we can say. So one of the things we want to do is we want to be one of the community-based predictors of diabetics, not only clinical and genetics, but that's very expensive for us. We cannot afford it. But the answer to that is not yet specific.
I know recently among diabetes physicians, there's kind of been this push to remove the type 1, type 2 label towards more insulin dependence and insulin resistance in order to kind of better assess care. Do you have any opinions on that, thoughts?
Thus far, I'm a very middle of the road guy, neither this nor this. I follow ADA recommendations. ADA has not yet come up with the changes. The only changes they have agreed is 1A, 1B, type 1, type 2, and other causes. Type 2 diabetics and in type 1 diabetics, there can be insulin resistance. Insulin resistance is exactly that insulin is not able to work, whether endogenous or exogenous. So type 1, type 2 is a bad classification in my view. The old classification would be insulin dependent and non-insulin dependent. That's even worse classification. So for want of any other term, better at this moment, we'll stick to that. Insulin resistance is part and parcel of type 2. You can reduce insulin, you can resistance, and you can reduce the need for insulin. I do not know, unless we're waiting for the next standards to be published in February. Until then, we will have to continue to use. However, unsatisfactory it may be. John?
Okay, yeah, so you talked about this issue, and Bill had the question too, if there's all this cost associated with diabetes on the inpatient level, but the leverage point to affecting diabetes is at the preventive and maybe at the outpatient level, what sort of business, but at the same time, Hoag Hospital isn't the payer for the patients, they just deliver the care. So how did you convince the hospital? I wanted to ask you this question for about 2 years now. How did you convince the hospital that the hospital itself may not ever save money because of the activities at the diabetes center, although society might? So how do you make that case? And maybe you could speak to what you're doing with the insurance companies too.
This will again My wife is talking to me now. I'm not a schizophrenic, but I can hear her. Cool it, cool it, cool it. At the end, this question was asked not far from here. Our CEO is a member of your faculty at the Berat School of Business. And he was asked to give health economics and what Hoag does, just like I'm being asked to speak. At the end of the day, it's the right thing to do. Period. That's it. That's the only motivation for most of us. It's the right thing to do for our patients. I mean, that's what we're here for. How did I convince? It was very easy. I mean, because it's the right thing to do. Now, whether we can convince the insurance companies, convince the manufacturers of devices and drugs to come to a grand coalition of commonly delivered. But can you imagine that all diabetics in Orange County are being cared for in the same way? I mean, I think it will not cost $180 billion. I don't think it will cost more than $1 billion. The savings on that, can you just imagine? But do we have the will? Do we have the capacity? Yes, our next project in this, I didn't address this, we are going to our own institution. We're going to challenge our institution. We have a center here. We have 6,000 employees. There should be at least 480 diabetics if 8% off. Give them to us. We will provide it. And we will reduce your cost of medication at the end of 3 years. That's our challenge. And then we're going to work with physician groups, industries to give us their patients. So, I mean, that's the only view. It takes about 3 years for the program to be successful, to show improved outcomes and reduced cost. Those are our next steps. Any other questions? So, yes, ma'am. Sorry, go ahead.
I was going to say, if you could change one thing, like or enact some policy locally in Orange County, like anything that you could do to help streamline awareness and education, what do you think it would be? I mean, where would we start?
I've learned a long time ago, life is not simple. In order to do that, there has to be a coalition of the willing. It doesn't matter. I mean, we have to have early adopters who believe that this is good. They say diabetes is worse than HIV in the next 10 years. So we need to have lots of people who are ready to do a little more than look after themselves. We need to, I mean, that's why public health is so important. I mean, you are the thinkers. Almost all the basis of all I've said here today is not from ADA book, it's from public health publications. So we need to have the courage to come together and say, look, this is a problem for our children, for our adults. Parents will bury their children, ladies and gentlemen, I promise you, if you not take care of them. Because they are 12-year-old, 250 pounders with hemoglobin A1C of 7. They have no future if we don't start controlling it now. So it will not be one, it will be many. There will be some who will not be interested, but this is a democracy. You can opt out. But there has to be a coalition of the willing. There has to be. UCI and Hoag must lead this effort in the community. Orange County has a poor health. I mean, they just gave away UCI Medical Center for $1 because Orange County did not want to take care of the poor. So I'm not a politically active. I have no desire to be. I'm not a policy advocate. But there has to be a coalition of the willing to develop that. I don't think there is one. The one thing I would say is passion. Yes. Next.
For the women who develop gestational diabetes,
yes.
What are the effects on their children?
Yes. Very interesting question. Gestational diabetes is a condition where women during pregnancy develop type 2 diabetes. And majority of the time, soon after the birth of the baby, as soon as the baby is born, the diabetes disappears. So that is gestational diabetes. The long-term prospects in them, 50 to 70% of them will become diabetic between a year and 10 years. Think about those women. We have 4,000 deliveries in our hospital. We have about 300 patients. We have a slightly higher incidence of gestational diabetes at home because most of our childbearing women are what we call mature women in their 30s and late 30s. Don't get nervous, but that's fact of life. We have our women come in their suitcase on Friday evening. Induce me. I'm going back to work on Monday. So that's our population. So we have a slightly higher incidence of gestational diabetes. And the babies are big. So there's birth trauma to mothers. The babies do not have, they have hypoglycemia, the babies have to go into ICU. The babies have congenital abnormalities. So, and those babies and those mothers have higher incidence of diabetes down the line. The fascinating thing is, it's different in Vietnamese, it's different in Indians, it's different in Caucasians. So we need to develop different programs. Sure. Yes.
Do you have a niche for like spatial epidemiology using GIS to understand the population better?
Come and work with me. I'll give you a room, I'll give you a computer, you can sit there and work all day, we'll get it done. That's your practical. Dylan, you got a practical.
Yeah, absolutely. She's already improving.
I don't even understand the question. See, that's it. I've always got out of my lip, BS a lot.
But you showed a map of the United States with prevalence.
Right.
And I was looking to see if there is a pattern.
Yes. The pattern will change because it depends on the population. I'm sorry, I don't know. But there is, I can give you pictures. I mean, you all have access to that. Various populations in the United States have different propensity for diabetes and higher incidence of diabetes. It's a constantly moving, public health people know how to answer this. It's constantly moving targets. The more Hispanic population, the more wealthy they become. They eat the food but do not do what they're supposed to do. So it's a shifting population. But there are pockets in all cities and states where there's higher incidence. Any other questions? Yes.
So it's encouraging that you are able to have this foundation and serve underserved populations that don't have the ability to pay. And you say passion is a part of that. Do you have like any practical advice in that regard? Because I think a lot of us are interested in finding ways to serve underserved populations that aren't very profitable.
You know, I will have you all day on a Sunday at the center. We'll provide you lunch and bring all your friends together. And you remember I said community service, culturally sensitive community service? We can have a meeting one day and we'll bring Dr. Patty, who's the community medicine director, who's more passionate about this than I am. And we can have lots of people in the community work, Latino Health Access, moms, SOS Clinic. We are actually, as a matter of fact, John and I are working on SOS Clinic and helping Spanish-speaking women. We cannot bring them to the center. They get intimidated. I mean, you saw the center. It looks very, it's like lobby of Four Seasons. It's really very fancy. But we need to take management to them, to their home. So there are many methods. You do not have to take the whole world. You can take a pocket, isolated area, and work with them and hand it over to the next year's students. And it needs to be continuous. Continuum of care is the bane of American healthcare. There's no continuity of care. 20 different people, all of them. I saw a lady this morning, she had seen an oncologist, she had seen a radiologist, she had seen an endocrinologist. I don't have any of the records. She came for a second opinion. How can I give a second opinion if I don't? The lack of continuity, the lack of cohesion among various forces is sad, very sad. The way every doctor rewrites the history. Why? I mean, some of my colleagues, very high forceful, what they do the charts, download in a flash drive and give it to the patient, take it with you. And I think that's something like that. Any other questions? Sir.
I guess two questions. First being, how effective is prevention in reducing incidence when you're only teaching prevention to those who already have an increased risk or have diabetes themselves? And if you're focused on, is there any efforts in trying to promote prevention outside hospital to those who don't necessarily have an increased risk but may longer down the line?
Gilly, you've got very smart students. Very good question. Diabetes is not disease of the hospital. We must get out of the hospital-based care. It should not be. It's a disease of the community. So diabetes care may cost us 51% of the $180 billion in the hospital. We must not. I mean, one of the conventional chief operating officers asked this question: why are you doing this, preventing these complications? How will we make money? Because Friday afternoon, 2 o'clock, this was the question. Friday afternoon, to business development office. You see, that mindset should change. It is not about taking care of patients who are sick in the hospital. It's about keeping people outside the hospital, keeping people well. I mean, there's a shift in emphasis, shift in thinking. That's why Hoag Hospital is. We are not going to invest a lot of money in hospitals. We're going to build a lot of outpatient facilities which combine prevention possibilities. So that's number one. So don't think hospital, think outside the hospital, think community. The reason why I'm interested in, and I'm being very careful, I'm not interested in taking care of problems which I do not know anything about. Wellness, health maintenance, I do not. But chronic health is diabetes. I know that we can prevent that diabetes from happening in substantial number of patients, 60% reduction. And in the onset of diabetes, 5.5. Lawrence, when he comes, he's going to have all these details given to him. Get me a weight reduction program for diabetics and weight reduction program for prevention of diabetes. So those are evidence. Now, I do not have evidence to show that these people will not have complications. I do not have evidence. But that is, I have to surmise. I'll tell you, there are a couple of studies that were done. There is a study called BCCT, the Diabetes Complication Control Trial. It was done at an expense of $100 million. 3,000 young diabetics, type 1 diabetics, were followed for 10 years. Some of them were controlled tightly, some of them were not. The study was stopped by 6 years because within 6 years the expected improvement in complications took place. So that established scientific fact. The same group were followed 10 years later. Those who had tight control drifted to poor control. Those who had poor control drifted up to better control. Guess what? Those people who were very well controlled during those 10 years still had better outcomes in their lives, and those people who were not had increased death of cardiovascular disease and mortality. So if you do it well, if you do it well early, and if you do it well before complications come in, you seem to do well. That has been confirmed in various studies, ACCORD trials and others. So my argument is, don't wait till the problems come in. If you are predicted to have diabetes, prevent it. If you have diabetes at early stages, control it. It's too late for a 75-year-old man who had a stroke, heart disease, kidney failure to try to control it. They'll die sooner if you try to, because it's over. So the aim of all projects we do at the center should be prevention and documenting over longitudinal time that made a difference. Some of it is assumption, but I think healthy assumption.
I was curious, we need to get the word out to the community about how to get them information about diabetes, about prevention and all that. How do you think, I mean, you're in SOS, so has that been effective, or is there a model, or is this just starting?
These are all, I mean, John has been with me for the last 2 years since the center opened. He's helping us with all this effectiveness of what we do. I do not think we have made a change. We've made a difference. But it's a long-term plan. We want to be constantly inventing ourselves. That's why I said we need to have a coalition of the willing and actively participating. SOS is our main focus, so we need to study the effectiveness. I do not know how effective. Thank you very much.